Working in behavioral health or managing an organization in the industry can be challenging. Regulations are constantly changing, and staying compliant is harder than ever. That's where the Behavioral Health Association of Providers can help. BHAP is a national association for those who work in behavioral health or addiction treatment. One of the ways we serve the community is by offering educational opportunities such as CE-based webinars and our certificate in addiction treatment marketing. BHAP also provides advocacy information so you can stay on top of new laws and regulations that will affect how you do business. Our members benefit from simple, effective, and relevant resources that keep you focused on what matters most, the health and well-being of your clients. Helping small and mid-market behavioral health providers access compliance resources and legal education, BHAP is the leading and unifying voice of treatment programs. You can find out more information, as well as sign up for our various newsletters, on our website, www.bhap.us. Hello! I'm glad you could join us today. Welcome to the webinar, Reclaiming the Podium, Making SUD a Policy Priority Once Again. My name is Amy Sutton. I apparently can't talk today. And I'm with the Behavioral Health Association Providers, whose video you just saw. And now, it's my pleasure to introduce our presenter today. Andrew Kessler, JD, is founder and principal of Slingshot Solutions, LLC, a consulting firm that specializes in behavioral health policy. His clients, past and present, include the International Certification and Reciprocity Consortium, ICRC, Faces and Voices, and of course, BHAP. With 20 years of policy experience and over a decade in the behavioral health field, Kessler is a fixture in circles that advocate for substance abuse treatment, prevention, and research. He collaborates frequently with congressional offices, the White House Office of National Drug Control Policy, the National Institution on Drug Abuse, NIDA, the Substance Abuse and Mental Health Services Administration, SAMSA, and other federal actors. Kessler has written legislation and report language adopted by both the House and Senate Appropriations Committees, and has presented orally before such bodies as the Scientific Management Review Board, the National Conference on Addiction Disorders, and the College on Problems of Drug Dependence. Andrew, thank you for taking the time to present today. With that, I hand the webinar over to you.
Thank you, Angie, and good morning to everyone. It's early afternoon here on the East Coast in Fairfax, Virginia, right outside Washington, D.C. Just some housekeeping notes. I apologize for the audio in advance if there's a slight echo or reverberation coming from my end. I'm in a new office with no furniture, so there's not much to dampen the sound, so I apologize for that. And of course, as with many of us during these times, it is a home office, so the only risk of being disturbed on my end is my 6-year-old beagle, Lolly, who may be scratching at the door trying to get in, trying to see what Daddy is up to. But barring those two minor inconveniences, we're going to get started with our presentation, and I'm going to share my screen and my PowerPoint presentation. Hold on. How are we looking? Angie, can you just give me a okay if we're good here? Angie, or is the screen good?
You are perfect, as always.
Okay, thank you. Thank you. Ooh, tell my wife. Okay, so here we go. As Angie mentioned, I work in Washington, D.C. on federal policy concerning substance use disorders and other behavioral health issues. And it's been quite interesting the last few months, to say the least. From 2014 through most of 2019, the opioid and overdose epidemic was easily the single most talked about issue in healthcare policy, which was strange for us at first because we were coming off of years, if not decades, of very little people giving us any attention whatsoever. And that exploded in 2014. I remember the date so well because I remember giving a presentation in 2013 saying that this would never be an issue that politicians really like to key in on because there was too much stigma surrounding it. So mea culpa on that one. But from 2014 to 2019, we were in the spotlight like nobody's business. Stories on major news networks, stories in major newspapers, politicians, presidents, all talking about this issue. It was, good to have the attention, but we were still not where we wanted to be in terms of recognizing the shortfall of resources that were being applied to the issue. In that span from 2014 to 2019, we saw two separate standalone bills passed concerning substance use disorders. One was the CARA Act of 2016. The other was the Support Act of 2018. Both passed in the House with over 400 votes, I believe. Both passed in the Senate with over 90 votes. Truly a bipartisan issue. And then came the pandemic. And when a issue of that size impacts the nation, Congress has little time or little will to address much else. The focus on COVID over the last 2 years, to the exclusion of other issues, is rivaled only by one other event in my lifetime and my career in advocacy, and that is 9/11. For 2 years, for a good 2 years after 9/11, if you weren't talking about Homeland Security, you were not talking. And the same really happened this time around for COVID. It was all Congress wanted to talk about and felt they could talk about. So we were kind of, I don't want to say shut out, but we lost that podium real quick. We lost that top spot on the podium fast. And we always knew it would happen. We just didn't think it would happen that fast. That's the way Washington works. Things go in cycles, issues go in cycles. And, today, May 10th, 2022, COVID is on top of the podium. It is the most talked about issue on the Hill. Ukraine is probably in second. I don't know where SUD ranks. I hope we're still a fairly popular issue, but we're definitely not the most talked about issue anymore. Now, COVID wasn't just an impact, didn't happen in a vacuum. It had an impact around the country. It affected the economy, it affected politics, and of course it affected health and behavioral health. It wasn't like, we had all the resources we needed beforehand. But when everyone's talking about one thing, you have to frame your issue to find the intersection with that one thing. So for example, when I talked about 9/11 at the time, I was representing a group whose interest was psychology. So we would talk about facial recognition or behavior or charting human behavior, things like that, things that could be applied to Homeland Security. In this situation, we needed to talk about the impact of COVID on behavioral health, whether it be mental health or substance use disorders. I want you to take a look at this. I'm not giving you this for news. The audience on this webinar knows full well what these statistics are. Nothing bothers me more than tuning into a talk or a webinar or going somewhere and being lectured on what I already know. I know you know this, but there's a reason I'm showing you the trends in U.S. drug overdose death. You can see how they spiked, but I want you to take a look at the x-axis and take a look at the very last year on the x-axis. That's 2019. That's before COVID ever reached the United States. We were facing these problems before COVID ever came around. So we know that COVID exacerbated these problems, or we should say, we know that there was a spike in overdose deaths due to COVID, but COVID didn't cause these problems. They just exacerbated them. We were on this upward trajectory long before COVID hit. A lot of policymakers like to say, oh, well, it's due to COVID. Well, some of it, yes, but let's not ignore the past. You don't know where you're going unless you know where you've been. And where we've been is a very challenging road in terms of trying to get a handle on the number of overdose deaths. What's ironic is that this all began, or the policy and the talk about this on Capitol Hill started with prescription drug abuse. And you can see that yellow line on this graph. That's the only area where overdose deaths were coming down. It's synthetics, it's fentanyl analogs and other synthetics that are really driving this. So you can see here, we were in bad shape long before the pandemic came around. That doesn't mean COVID didn't have an impact. It did. There was a 28% drop in patients initiating treatment in the 8 months after the pandemic began. This could be due to a number of factors: people not wanting to leave the house, people not being able to leave the house, people dealing with other health problems, such as COVID. But this was just in the beginning of 2020. And by late 2020, we hadn't seen a return to pre-pandemic levels. You can find these facts in the Journal of the American Medical Association. So let's talk about how Congress responded to COVID, because like I said, you can't know where you're going until you know where you've been. And I know the topic of this talk is reclaiming the podium. You have to know where you are at this point to be an effective advocate. You can't just jump into the middle. You need to learn how to swim before you jump in the deep end. Doing it the other way around isn't really advisable. And I want you to know exactly what kind of situation we're in, so we know exactly how to frame our advocacy to fit the current situation. Most of the money in the December 2020 COVID economic relief bill, most of the SUD money that was aimed at substance use disorders, went to the Samsa block grants. A little bit went to some CCBHC, Certified Community Behavioral Health Centers, but most went to the Samsa block grants. For those of you not familiar, the Samsa block grant is a mechanism by which states apply for federal funds every year. Whatever funds are received, the state gets to use a state discretionary funds on any SUD services that are not covered by Medicaid. States receive money based on population. So it's very simple. California gets the most, Rhode Island or Wyoming, or whoever's 50th, probably Wyoming, gets the least. And that is it. It has nothing to do with how bad the problem is in your state. This is a population-based grant. So New York, Texas, Pennsylvania, Ohio, they get more money than, say, Delaware, West Virginia, South Dakota, population-based. So $1.75 billion went to the SAMHSA SAPTG block grant, Substance Abuse Prevention and Treatment block grant. 20% of that goes to prevention by statute. To give you an idea of what kind of appropriation this was, the annual size of the SAPT block grant is $1.8 billion. So they were basically giving SAMHSA a full another year's worth of funding, which on the one hand, mathematically, is quite impressive. In the real world, we are so ridiculously underfunded in terms of the challenges we face that it's still not enough. So that was in December 2020 as President Trump was preparing to leave office. Then President Biden takes office and we get another bill, which passed in 2021, called the American Rescue Act. That provided another $1.5 billion for the SAPT block grant. So now, for funding for that fiscal year, this would be fiscal year 2021, Samsa has received almost triple what they're used to spending. They received their regular appropriation of $1.8 billion. They received $1.75 billion in December of 2020, and then another $1.5 billion in March of 2021. Now that's a lot of money and not easy to spend. It's not like they could just throw it around willy-nilly. They need to know, states need to know where that money is being spent and that it's being spent effectively. So what Congress did was they said to SAMHSA and the states, for the money you receive from the COVID packages, which is a total of $3.25 billion, you will have 2 years to spend that down, not the regular 1 year. So states now have 2 years to spend that money on block grant services as they see fit. So all things being equal, we were for the most part pleased with these appropriations. We figured that, sometimes in advocacy, you got to know when to say when. Don't look a gift horse in the mouth. Pick your cliche. Say thank you. Move on to the next, next fight. So that's how COVID impacted our funding. You keep hearing me use a word I keep saying how much was appropriated, and that's an important word. Often I am guilty of thinking everyone speaks the language I speak, and the language I speak is DC. And that means throwing around some words and some acronyms and some initials that not a lot of people are familiar with. I say things like SAMSA, I say things like HRSA. Those are government agencies that are acronyms. And I say things like appropriations. Think of it as an allowance. It's money that is given out to a program. If a bill is passed, I want you to think of it this way. Let's say a bill is passed. Let's say the government is going to spend $50 million on something, A, B, C, X, Y, Z. And I want you to equate that to your mother or father when you were a kid saying, we have decided to give you an allowance of $10 a week. All it is an intention. It's a declaration. It's saying, I'm going to. The money doesn't get delivered to the program until the appropriator said so. So when your parents actually hand you that $10, that's the appropriation. When the money is in hand, when the appropriators have to say, we are spending this money. Doesn't matter what the bill said. The bill could pass saying we're going to spend $100,000. A bill could pass saying we're going to spend $10 billion. Until the appropriators say, here's the money from the Treasury, the money doesn't exist. We have a saying in Washington, the president proposes and Congress disposes. And I want you to remember that because it's going to come up again later. Or put another way, we have another saying, there are three kinds of politicians in Washington, D.C. There's Democrats, there's Republicans, and there's appropriators. The members of the Appropriations Committee in the House and Senate are incredibly powerful. They decide where the money is spent. And for my money, when it comes to advocacy, there's two pieces. One is getting the bills you want passed. The other is getting the money to make them a reality. Because you could pass all the bills you want until the Appropriations Committee says, here's the money to fund the programs you are interested in. They don't exist. You just don't have the money. So, FY22, FY is fiscal year. That's our current fiscal year. Now, normally, in an appropriation cycle, Congress wants to be done by mid-fall. September 30th is when the fiscal year ends of the previous year. This time around, during this process, it got delayed and delayed and delayed. And part of that was due to the pandemic. President Biden took office. He had to deal with the pandemic. Congress was expecting a budget proposal from the president in March or April. They didn't get it until June because the president was so busy with the COVID money, they started to decide that they would do their own appropriation without the president's recommendations. They didn't know how much money would be available, and the process was a mess. So what was supposed to be done by October of 21 didn't get finished until March of 2022, which is the latest I've ever seen it. Once again, I've been doing this for 20 years. This is now, it's nothing new or revolutionary in Washington for the process to take a long time. You go through continuing resolutions. You have what you see on the news as shutdown battles. Was the government going to shut down? So and so and so. What we have here is a unprecedented delay. So we're just getting used to, we're just getting adjusted to what the FY22 appropriations ended up being. During this process, the president wanted to see the SAPT block grant at Samsa increase from 1.8 billion to 3.5. The House said, we'll go 2.8, which is a fair compromise. And the Senate recommended, I don't want to say the Senate recommended, the Senate legislation, which never actually passed, recommended $3 billion. This would be the first increase in the block grant in 13 years if it became a reality. And I want you to see why that's so important. The SAPT block grant has been flat funded for over a decade. What does that mean? It means it gets the same money every year. There were years from about 2013 to 2017 where if you were flat funded, that was actually a good thing because so many programs were losing money. We would come out of meetings and say, hey, at least we're not getting cut, and consider that a victory. Those days are over. You want to see increases. Not only do you want to see increases because spending is up, you want to see increases because if you look at this graph, if you're flat funded for 13 years at these levels, you don't keep up with healthcare inflation. And if you adjust for healthcare inflation by being flat funded for 13 years, 14 years, the block grant has lost over $577 million in purchasing power. So we really haven't been flat funded. We've been losing money on the block grant. So we really, really, really need this increase. The White House, in addition to proposing this increase, proposed a 10% set aside in the same block grant to go to recovery support services. And the House of Representatives and the Senate both agreed that this should be done in their respective chambers. Of course, a law is not a law until the House and Senate agree on every dotted I and every crossed T. I'm going to skip that real quick. What ended up happening was in the final package, the increase was not there and the set aside was not there for a variety of reasons. The reason the increase wasn't there was because when the House started creating their budgets, like I said, the process was so screwed up, they really had no idea how much actual money they had to spend. The way it works is the same way it works with every budget. Imagine you're running a major company or a treatment center. You've got to account for different departments. There's payroll, there's insurance, there's purchasing. There's a variety of budgetary considerations in any situation. And in Congress, the way it works is the budget is a set amount of money. And then you say, well, these 12 appropriations committees are each going to have this much money. And then you say within those committees, well, these government agencies are going to have this much money. Then within each agency, you can say each of these programs is going to have this much money. And so, and so, and so. We call it the bird pie. Why? You start out with a big pie and you set it out for the birds to peck at, and the birds come and they peck and peck and peck. And in the end, what's left? Nothing. We call it the bird pie. So the House and Senate started creating their budgetary numbers without a lot of guidance as to how much money would actually be available. When all was said and done, their estimations of how much would be available for the Department of Health and Human Services was off by about $30 billion. So cuts were going to have to be made to the original plan. So there goes your $1 billion increase. As for the set aside, it was kind of accepted that the set aside for recovery support services was not going to happen unless the increase happened. So no increase, no set aside. So now, just as we're finishing up 22 in March, what happens? The president's plan for 23 comes out. Usually you've got a few months to take a breath. This time it didn't happen. So the president last month, 2 months ago, about end of March, I want to say right after the State of the Union, released his budget. And it's very difficult to look at the president's budget and say, oh, it's good news, because the best you can really do is avoid bad news. Remember what I said before, the president proposes and the Congress disposes. All the president's budget really is a statement of administration priorities. Rarely, if ever, is a president going to veto a budget because it didn't address his priorities. And if they do, it's going to be a major, major priority. Something like Reagan and welfare reform or Medicaid reform. Something like Obama and the ACA. Rarely is a budget going to be vetoed simply because Congress made some changes to it, or many changes to it. So really what you're looking for in the budget is to avoid bad news. You don't want to see cuts because that puts you in a hole when you start negotiating with the House and Senate. So that being said, the president recommended the same budget in FY22 and FY23 as he did in 22 with regards to Samsa. Recommended $3 billion for the SAPT block grant. Recommended a 10% set aside. We actually are getting resistance on Capitol Hill as we talk about this because there are some lawmakers who said, well, you got that extra $3.5 billion in COVID funding, so do you really need the increase? Well, yes, we do, because last I checked, there were still 100,000 overdoses a year in the United States. That hasn't come down. So until we get our increases and we know how much actually is enough, we're going to keep advocating for more. So we're in kind of the same place as last year. The advantage we have is we're going to know a lot sooner from the House and Senate how much money they're playing with at an earlier date. So we're not going to get caught by surprise when they promise us, when the House and Senate delivers their numbers and say, here's X, here's Y. They're not going to have to say, we're going to have to come back in 6 months when we find out what the numbers really are. We're going to know much, much sooner. So why? It's an election year. No politician wants to look like they're not bringing home money to their district in an election year. So appropriations should move faster this year. So it was a pretty solid budget. There were increases for the block grant. There were increases for some workforce loan repayment programs, so on down the line. We were fairly pleased. Not surprised, but pleased. There was also some mentions in the budget of harm reduction, increasing harm reduction programs, and a few other things we support. So the really interesting thing to come out of the budget this year wasn't a monetary increase or decrease. It was a change in language. It was recommended by the president's budget, or you could read it in the president's budget, that every federal agency that contained the word abuse in its name had that word removed from the budget. So the National Institute on Drug Abuse was referred to as the National Institute on Drugs and Addiction. SAMSA, Substance Abuse Mental Health Services Administration, was named the Substance Use and Mental Health Services Administration. Once again, this document, this budget, has no force of law, but it's making a recommendation to the Hill. And as far as I know, these agencies are on board with the change. NIDA probably lucked out the most because they don't have to change their initials, and I know that was a sticking point for them. No, I'm not kidding. But SAMSA would have to become SUMSA. That could be a tough adjustment for some of us. Hey, I'm in Washington, D.C., where the Redskins have just changed their name to the Commanders, and I'll tell you, no one in D.C. is calling them the Commanders yet. It takes a while to get used to new names, especially when the name's been around for 40 years. But that was a nice little nod, I think, to our community. I think that was a recognition of, hey, we understand what's important to you. We understand stigma, and we understand that, attitudes matter. And that was a nice little nod from the administration. If someone is going to come to me at the end of the day and say, you can have the name change or you can have your $1 billion increase, what are you going to do? I'm a lobbyist. I'm taking the increase. But that being said, all things being equal, I would like both. Recently, I think just 2 weeks ago, the Office of National Drug Control Policy issued their drug control strategy. This is a document that's issued every year by ONDCP. Once again, in 2021, this is usually expected in the late spring. And in 2021, the new White House was so overwhelmed with COVID, they never issued a strategy. They did issue a release on what their priorities were. So this was the first national drug control strategy released by the Biden-Harris administration. And those 7 priorities that were released last year served as the framework for the priorities of this strategy. You can read them there. The one thing that's kind of new from this White House that no other president has recommended in the past is that third point, enhancing evidence-based harm reduction efforts. There's a big push from this White House to make harm reduction less stigmatic, less ostracized, more accepted as part of the regularly functioning, machinery of SUD treatment and recovery. So that's really the groundbreaking issue in this report. The rest, it's more of the same. The strategy doesn't change much year to year. Sometimes there's an issue that really drives the strategy, like in 2014 with the incredible number of prescriptions for OxyContin we were seeing, or even before that, the spikes in methamphetamine. You'll see different things take different forms, but at the end of the day, the strategy is pretty static, stays pretty much the same. So that's where we are with the position of the White House. It's one we can definitely get behind. No real controversy there. So let's talk about the current environment. I've got about 10-15 minutes left and to talk before I take questions. And I want to talk about, where we sit in terms of the current environment on Capitol Hill. You'll remember earlier I said that from 2014 to 2019, this was probably the most talked about issue in public health. If you had to ask me right now, outside COVID, what's getting the most attention, I would probably say mental health is getting a little more attention than SUD. And in a vacuum, I'm not mad at that. All things being equal, we all know what a role mental health plays in substance use disorders, how much it impacts substance use disorders, and we all know how much we need to treat the whole person. Quite often, someone presents at our door needing both services. And mental health is quite underfunded as well, although maybe not as much as SUD, and it's just as much of a crisis. However, that's in a vacuum. In reality, when it comes to appropriations and funding and programs that are the responsibility of the federal government, more often than not, mental health and SUD programs are siloed. You have SUD programs on one side of the ledger, you have mental health in another part of the ledger, and unfortunately, sometimes we have to compete for attention. We do work together too. We work together actually quite often. More than we don't. But at the end of the day, most of the work I do is on the SUD side. I do a little mental health work as well, but unfortunately, when you advocate for a program, it's usually on one side or the other. So what that means, and they're also funded out of the same agency. And I was talking about that bird pie before, and when Samsa gets its piece of the bird pie and says, you have X billion dollars, they've got to decide how much are we spending at CMHS, Center for Mental Health Services, how much are we spending at CSAT, Center for Substance Abuse Treatment. You got to get in there and say, my programs are more important or the most important, or fund this. It's tough. We have to compete with mental health when we should be collaborating with them. So there is a big emphasis right now on mental health, suicide, and crisis care. Crisis care is a huge part of what everyone's talking about in mental health. Why? Well, obviously, COVID was not good for this nation's mental health. I could have told you that right when it started. I actually did. People said, how do you think this is going to impact mental health and SUD? And I said to them, I think it's going to be horrible. They said, how do you know? I said, well, I'm not a psychologist. I'm not a counselor, but I think it's a pretty simple formula. Fear and isolation are not good for people with behavioral health challenges. And that's what we're about to face. You know, we knew it would drag on this long. We thought it would be a few months. 2 years later, fear and isolation have caused serious mental health and SUD challenges. Mental health has a nose in front right now. And I don't want to say that. That's not saying like, oh, we got to get out there and, get ahead of them. I'd like to see both of them together. But right now, if you were to say to a committee member who has jurisdiction over these issues, what's your big priority right now? They may say mental health over SUD, whereas 2-3 years ago, it was SUD. So that's where we're at. How are we addressing mental health and SUD in this post-COVID world? Let me tell you what the 3 priorities are. And this is not any list that was made or any resource you could find. This is how I read the situation. This is what I hear on Capitol Hill. This is the chatter. This is what I see is occurring most often. If you're familiar with word clouds and like how often a certain word is used and then it takes up a bigger space on the page, this is what I see when it comes to behavioral health post-COVID. Telehealth, obviously, exploded during COVID. People want to see changes that were made to allow telehealth to grow, stay in place. The effectiveness of telehealth was huge, and people want to see telehealth expand. 2, peers. A lot of members of Congress are interested in workforce, and I'm going to get to that in a few slides later. But more so than workforce, whatever you say to a member of Congress these days, let's talk about workforce. They want to talk about peers, which is tough because it's a young profession, it's an evolving profession, and we're kind of building the plane as we fly. When it comes to standards, when it comes to their role, when we come to what their role is in different states, peers are an evolving profession. And I have seen 2 states that border each other, Maryland and Virginia, where I live, have completely different standards and expectations of roles for peers. So it's a tough call. And the third is the role of the community in crisis management. The response of the community and how communities can adapt and influence crisis management so it works best in their communities. Those are probably the biggest priorities in behavioral health right now. I'm going to talk about those just a touch more in depth. I want you to know these 3 numbers, 988. This has been years in the making. Several years ago, it was proposed that we need a nationwide 3-digit suicide hotline. If someone were in crisis, and they wanted to call the suicide hotline, you'd have to Google the number, and God knows what would come up. You'd have to, you would, the ability to be answered would be dependent on, the underfunded resources of your state or community. We're going to try and do away with all that with a simple 3-digit code. So you have 411 for information. You have 911 for emergency. The National Suicide Response Line, hopefully it'll be up and running in July, is going to be 988. And that's going to be the National Suicide Prevention Hotline. Now, we only see this as a beginning in building the first step of a nationwide crisis response network. It is due to go live in July 2022, but what a lot of members of the advocacy community and activists have, the question we have, as well as members of Congress, is what happens after the call? Okay, obviously, if you call 988, you have an urgent situation that needs to be addressed, whether it be mental health, whether it be substance use, whether it be something else, whether it be a financial problem, an abusiveness problem, any number of things. What happens next? We can't hang up and say, have a nice day. So that's where we need to build the network. Who can you be referred to? If I were to call 988, they need to be, for it to be fully effective, one, they have to succeed in, talking to me and making sure that I get through the call okay. They have to say, oh, sounds like you have a problem with methamphetamines. You're in Fairfax, Virginia. Here's a number to call. Would you like me to connect you? Would you like me to? You see, this is the first step into the entry of a larger crisis response network. That's why 988 is going to be so important. And that's what we're working on developing. There are many members of Congress who have introduced, I think there's 3 different bills right now revolving around 988 about how we can use this to expand accessibility to services. So very important. The House currently has a mental health and substance abuse package. In DC, it's called a package because imagine a care package you get from your mom or your grandma when you're in college or school. Lots of little things. Oh, here's a box of Cracker Jack. Here's some Twizzlers. Here's some Snickers bars. Lots of little things. In legislation, a package is a bunch of bills that come together and are introduced as one. So right now, the House just unveiled their big mental health and SUD package, and it does 2 things. One, it reauthorizes some programs in Samsa. Now, I don't want anyone to get their hopes up because it doesn't recommend any big increases and it doesn't recommend a recovery set aside. 2 things we were really looking forward to. So we were a little upset about that. In addition to the Samsa reauthorization, which reauthorization is just a fancy word for renewal, it establishes a behavioral health crisis coordinating office at Samsa to deal with these 988 issues that I talked about. And it requires the secretary acting through SAMHSA's assistant secretary to collaborate to promote the availability of high quality recovery housing. I know a lot of you are in the recovery space. And if you work on recovery housing, this is finally, we've got the Excellence in Recovery Housing Act, living, breathing, and jumping, and it's actually in a piece of viable legislation. So there's some good news on those 2 fronts. The SAMHSA reauthorization that didn't contain any increases for the agency, we weren't so thrilled about. I challenge you to meet the person who gets everything they want out of a package this big. And on the Senate side, there's no less than 3 behavioral health packages being considered. One has to do with SAMHSA reauthorization. One is from the Finance Committee, and one is from the HELP Committee, HELP being Health, Education, Labor, and Pensions. And I know you're probably thinking of that old Sesame Street gig, which one of these kids is doing his own thing, which one of these kids doesn't belong. You may be scratching your head and say, why is the Finance Committee working on mental health and substance abuse? And the answer can be summed up quite simply in 2 words: Medicare, Medicaid. Remember I was talking about appropriations and how the money is decided by Congress, how much gets spent? That's something called discretionary spending. There's also something in the United States called mandatory spending, which means the money just goes right to the program. Congress doesn't have to approve it. Every year, the money goes out the door. These are things like veterans benefits, interest on the debt, Social Security, and Medicare and Medicaid. Some people call them, quote, entitlements. I don't like that word. I like mandatory spending. The Finance Committee controls mandatory spending, which means they control Medicare and Medicaid. If you control Medicare and Medicaid, you control behavioral health services. I was talking about the billions here and there for SAMHSA. Those are just grants to the states that fill in the gaps. The main driver of coverage for behavioral health in the United States is Medicaid. So if the Finance Committee has ideas on how to reform Medicaid to expand services, you're going to have to deal with them and listen to what they say. And they had a really interesting point on workforce. Their priorities were workforce, youth, access to care, parity enforcement, and mental health. Here's what they had to say about workforce. I do a lot of workforce issues in my advocacy. And this is directly from the Finance Committee's report. They were first out of the gate with their blueprint. And it says, although it's widely recognized that access to behavioral health providers is insufficient, data and projections to the extent of the shortage are inconsistent, which I have to agree with. I've seen projections that vary greatly. What they do agree on is this: the shortage to reflect insufficient adult psychiatrists and addiction counselors in 2030, if there are no changes in behavioral healthcare utilization, and anticipates an adequate supply of remaining health practitioners to meet the needs of Americans. Any shortages they crunch the numbers on, the only place they found really insufficient numbers is adult psychiatrists and addiction counselors. We've got social workers, we've got licensed professional counselors, we've got marriage and family therapists all saying they're shorthanded. And that may be the case. What the committee found in their data is that what the shortage really reflects is just in two areas: adult psychiatrists and addiction counselors. The other big thing going on is parity enforcement. We all know that the Mental Health and Addiction Parity Act has been in play. It's been in existence for 14 years, but what good is a law if not enforced? And what the committee discovered is that it's really not being enforced. It's kind of a toothless tiger right now. So reports have noted the full extent of noncompliance. They know, Congress now knows how much noncompliance has cost those seeking benefits. So even though the Treasury Department has the authority to levy a tax on noncompliant health plans, the Department of Labor has never referred a noncompliant plan to Treasury. You've got three agencies working on this. One, you've got HHS because it's a health issue. Two, you've got Treasury because it's a financial issue and insurance. And three, it's a labor issue, again, because it's insurance and it has to do with people filing insurance claims. So you've got three different agencies that need to collaborate on this, and it just hasn't been working. So Congress, for the first time since parity was passed, is at least taking seriously the fact that noncompliance has become quite a stone in our shoe, and they're finally acting on it. But it could take some time before we see some actual results. So in conclusion, before I stop talking and take questions, what I want you to take away is there's obviously, well, it's not so new anymore. It's been around a year, but the White House has different priorities than previous administrations of both parties, and they're willing to back them up. We are presented with a potential opportunity with all this interest in substance use disorder and behavioral health because of the impact of COVID. So we have an opportunity to reclaim that podium. It's just a question of how persistent and unfortunately how devastating this problem continues as. So I'm going to wrap it up, and all questions can be asked through the chat box. We'll have our moderator relay any questions. And
do you have a slide with your contact info by any chance? Okay.
I don't, but I'll put my Twitter handle.
That's fine. I've got the website in our thing as well. Okay. Barbara asked, how are you or they going to reduce the supply of illicit substances, expanding access to recovery support services?
Reducing the supply of illicit substances, always tricky. Here's what you have to know. Like it or not, this is a partisan issue. And there is a bit of divergence. Politics will always play a role in policy. Sometimes a large role, sometimes a small role. Right now, the Democrats are mostly in favor of a public health approach. Some Republicans are too. However, we all know how much of a political hot potato the southern border is, whether it be due to immigration or other issues. The southern border is kind of a calling card of the Republican Party. So any opportunity to bring the southern border into the political sphere, the Republican Party is going to jump on. We all know where fentanyl analogs come from. They come from Mexico. And so on this issue, Republicans are very much anchoring their strategy to shutting down the southern border. Is that going to be effective? No, I could do a whole nother webinar on that. I have done webinars on that. We, unfortunately, as a result of the 80s and the war on drugs, have created, the only thing I can make it akin to is a military industrial complex. We have a war on drugs industrial complex. There are billions of dollars that go into this industry. There's an entire government agency dedicated to it, if not three, and it's not going to go away. So the seizure of drugs is the responsibility of the DEA, a little bit of the FBI, but half of Capitol Hill, you have to understand, right or wrong, half of Capitol Hill thinks the best way to do this is through enforcement. And President Biden, being who he is, being a denizen of Washington for 50 years, he likes to, make everybody happy, find the compromise. So the nod to interdiction and seizure in a national drug control strategy, it's
Bill
on the board.
asks, do you think Lifeboat Act S1723 has any possibility of being passed?
Very little. The Lifeboat Act, I think this is the third or maybe fourth Congress it's been introduced, a Congress last 2 years by Senator Manchin. For those of you not familiar with it, it would tax prescription drugs 1 cent per milligram or something of the like, and the money would go to treatment. So we would tax things like OxyContin and so on, kind of like a beer tax or a tobacco tax, and it would go to the states to pay for treatment. Speaking of Democrats and Republicans again, you find me the Republican who says, yeah, I'm for increasing taxes at any point in any way at all. You can have a job with Slingshot Solutions. I've never found them. As worthy as the cause may be, as interesting as the idea may be, tax increases don't play. No politician wants to go home and have their opponent do an attack ad saying, he added taxes to your prescription drugs, because that's what they'll say. And they're not going to say it's OxyContin or, fentanyl or Percocet. What you're doing if you vote for this is you are gift wrapping to your opponent an attack ad aimed at seniors saying, he voted to increase taxes on your prescription drugs, and that's all she wrote. So I'm sorry, Lifeboat Act, I don't ever see it passing.
Okay, Susan says, not a question, but I'm glad entitlements came up. If SSA determines that someone is disabled and can't work, how can it be an entitlement? I look at it as a survival income.
Like I said, I don't like that term. I don't like the word entitlement. As an advocate, as a lobbyist, I call it mandatory spending. You call it what you want. I'm not a fan of that.
And while we're waiting to see if any other questions come in, just to let you know, I did put up the webinar evaluation forum link. That is just to evaluate the webinar. That is not the CEs. That will be sent via email. In the next day or so, hopefully by the end of today, actually, depending on how quickly it takes me to confirm attendance. Bill asks, how do you see Fight Fentanyl Act S339 playing out?
Oh, the Fight Fentanyl Act. Yeah, that's an interesting one. On the last one, I said, no, not going to pass. This one's a little trickier. I struggle with this. First, I just want to address the overall issue. I always get nervous when a bill or when Congress focuses on one drug. It's a phrase I started using. I like to think I coined it. I don't know if I did. I call it the drug de jure complex. I remember in 2006, all anyone in Congress wanted to work on was methamphetamine. I remember in 2015, all anyone wanted to do was work on OxyContin. And now all anyone wants to do is work on fentanyl. I do not deny fentanyl is what the problem is when it comes to the overdoses. But we're talking about one disease, and it's the disease of addiction. It's substance use disorders. The mechanism, to me, is secondary. So I just want to editorialize on that for a minute. The Fight Fentanyl Act does have bipartisan support. You not only have Capito and Manchin from the same state, both on the Appropriations Committee. You've got a fairly bipartisan, I wouldn't say centrist, but a decent, cross-section of supporters. So we're going to have to say that I think parts of it can move. What happens, all pieces of legislation at the end of the day become a Frankenstein. Nothing makes it intact. So I think the spirit of the Fight Fentanyl Act, when it comes to either Veterans Affairs or patient safety, I think aspects of it have a chance going forward. I don't know, with the three different Senate bills or the three different Senate committees all working at the same time, I'm not exactly sure which package it will make it into, or if they'll just choose another package and go to Veterans Affairs. With the Fight Fentanyl Act, it's not the substance. Like, someone asked me a question about the Lifeboat Act. The problem was the substance. No one was going to vote for that. Everyone pretty much agrees on the Fight Fentanyl Act, which has to do with safety of patients and so on and so forth. But everyone agrees on the substance. This is more a question of process. This bill needs to find a home. Which committee is it going to work best in? Who's going to support it? So I would say, it's got a 30 to 50% chance of making its way. Parts of it, I think, have a real chance. But again, when you focus on a specific drug, especially one that's legal, now you got to understand, fentanyl, as dangerous as it is legal. It's tough to regulate. It's in the hands of the DEA and the FDA when it comes to the end of the day. When it comes to regulation, we're not talking about cocaine or methamphetamine. It's a much tougher needle to thread when you're talking about a legal narcotic, regardless of how dangerous it is. But I think parts of it have a chance, but just not the whole thing.
Okay, we're wrapping up. One quick question: will these slides be shared with attendees? You are going to be sending those to me for me to upload. Okay, just confirming that they weren't proprietary.
Yes.
So yes, to answer the question about whether the slides will be shared with attendees, they are going to be uploaded with the recording that you will be able to watch again, and also where the CE questions are going to be, and that will be in that email that you'll be getting hopefully by the end of the day, if not tomorrow. One final question, then we'll wrap things up. Catherine says, who is our strongest legislator in DC? And also any work of 1115 CMS on 90-day in reach for justice involved individuals. Who is our strongest legislator in DC? It's kind of a two-part question. And then the second one, also any work of 1115 CMS on 90-day in-day reach for justice involved individuals. I put it up in the little button.
Oh, the 1115 waiver. Yeah. I can't really comment on the 1115 waiver. That's more of as much as it's applied to the federal government, it's more for the state to negotiate. So I'm really not well versed in the waiver, so I'm not going to answer that. When it comes to our best allies in DC, Doris Matsui of California is a great ally. She's always been supportive of the work we do. There's also Annie Custer of New Hampshire. There's David Trone of Maryland. There are people. There is a mental health and behavioral health caucus of which many of these members belong. In the Senate, there's I'm trying to think. There's definitely Chris Murphy of Connecticut. There's Bob Portman of Ohio, Sheldon Whitehouse of Rhode Island. We have our allies. It's just, I can't emphasize this enough. No matter how far we've come, we haven't come far enough. I have seen in 20 years how far we've come in terms of attitudes towards SUD issues, getting through the stigma, lawmakers understanding the issue better. We're still not where we need to be. We still have a lot of educating to do. There's still too many lawmakers and too many people who don't understand the complexities of SUD. And make no mistake, I see we're coming up on time, so let this be my final thought. Congress is a reflection of the people in every way, every day. What the people think, Congress thinks. And it's not only about educating lawmakers, it's also about educating the public. The more the public understands about SUD, the better Congress will understand. The opioid epidemic only became an issue because members of Congress saw their phones start to ring off the hook when people started dying all over their constituencies. So, we have a lot of great allies. We just don't have enough, and we still have too great a misunderstanding of what SUD and behavioral health is all about. So we still have a lot of educating.
Well, thank you. I wanted to thank Andrew Kessler for presenting today. For those of you who are unfamiliar with BHAP, he is our advocate in Washington, D.C., and provides a monthly advocacy update to our members that is available around the 15th, depending on when it lands. You can sign up for our various newsletters, which includes emails specific for upcoming events, at our website, www.bhap.us. With that, this concludes today's webinar. Thank you very much.